Hey everyone, today we're going to be talking about PCA and getting patients' pain under control. So first we need to know PCA stands for patient-controlled analgesic. This means a patient will be given a cord, oops, wrong one, a cord that has a little device on it with a little button, and they'll be able to push that button and get themselves some additional pain medication. All right, so what are things that we have to understand about PCAs? First, we need to understand the different medications that are going to be in there. So often we see morphine. Oops. We see morphine, which is a great pain medication. Sometimes we'll see a fentanyl PCA. Um, and then other times we'll see Dilaudid. This is the one that starts with D that everybody will say that they are not allergic to. It's because it is about 7 times more effective than morphine. And so it works really, really well. This is one we'll often use on patients who are not opiate naive. So our patients, when we're talking about pain medications, one of the things we want to pay attention to is we've got somebody who has never had a narcotic in their life. We do not want to give them the big guns first, or if we do, we give them little tiny whiffs of it. But if we've got somebody who has had a lot of pain medication, maybe a cancer patient or somebody who's had addiction issues and built up some good tolerance, we may have to start with bigger guns. So again, assess your patient, look at what they need, and make sure that we're giving them the correct medication. Here's the thing, we don't order that, the doctors do, but we can be the advocate for the patient and the family. Here are 2 examples of pumps. So you have this one that I see frequently used at hospitals. It's PCA. It's really big and blocky. This looks is probably a 30 ml of morphine in it, which is then a 30 milligram dose of morphine. So it's a 1-to-1 concentration. Not a big deal for you to know. That'll all be in the orders. But important to know that this is a really big thing. You see here that it has a key. It's not like people can accidentally push buttons on this one. You have to have the key in order to do any programming with it, and that's a safety thing so that we keep patients out of it. They can't just mess with the buttons and change their dosages. You see this little guy over here, that's a CAD pump. This is what I used to use with my home infusion patients. So you've got somebody with bone cancer, or I have an aunt with scoliosis, and her rib cage is really not stable, and so she has a lot of pain. She uses a little CAD pump, and you can program it to give the morphine, all that kind of stuff, same thing, but it is one where it's at home. She carries this at home. So it's a little bit bigger than maybe a cell phone, but there'll be tubing coming out of it and connecting into a patient, and they can control their pain that way. So we have some different options. No matter the different pump you have, it will all be set with the same kind of programming. So you have a PCA dose, which is this is the dose that they get. So like maybe say for our friend who has morphine, we're going to give them 0.05 milligrams, right? And then you have a lockout interval. So maybe we're going to give that to them. They can hit it every 5 minutes. Okay, and then their max dose, let's say the doctor sets it at 5 milligrams in 5 hours, right? Which that's kind of a little dose, but depending on your patient and what they're needing, that might actually be okay. Again, it's very subjective to the patient, and these can always be tweaked by us. And then a continuous dose. So this is somebody who maybe they just need a little bit that's continuously going in, and in addition to the little PCA bolus doses that they get. So maybe we're going to give 2 milligrams an hour, and we're going to set that all up for that patient. No matter which pump you're using, they use these same types of settings and mechanisms. So you've got your PCA dose, or your bolus, they sometimes call it a bolus dose. You've got your lockout interval, your max dose, and then your continuous. So now let's talk about some safety things that go on when we have somebody with a PCA. One, these settings need to be double checked by a nurse. I know a couple of great nurses who lost their jobs because they were busy, they were short-staffed, whatever, and someone did not check the do the second check on the meds. And this leads to bad things, which was a kid who got too much fentanyl and got overly sedated. So we want to make sure, protect yourself, protect your patient. I know you can set a pump. We can all push buttons. Here's the thing. We get busy, we overlook things, cursors move down to the next grid, whatever. So make sure you always have that second nurse check. All right. If you need to help them out by taking off a task off their to-do list so they can come check it, great. Work as a team. All right. The other thing is the O2 sat. And notice I said sat, not stat. There's no first T in there. So O2 sat, that will save you some embarrassment from the respiratory therapist. If you say, I need an O2 stat, they like to giggle. So O2 saturation, usually we like them above 90%, but depending on your order set, that may be slightly different. New things we're seeing come around is end-tidal CO2, which is the what your CO2 is at the end of air expiration. So if you're retaining that CO2, your acid is building. Now we're coming into a hypoventilative state, and then we're becoming acidotic. So we don't want that. That's bad. So you're going to see one of these two systems used, if not both of them. Other things we want to make sure is that we're checking respiratory rate. Pretty regularly, especially if they're an opiate naive person or if it's the first time on their PCA. If this person's been on their PCA for 2 or 3 days, probably not as big of a deal. You're going to notice their changes. You're going to get used to their patterns, but something that we want to pay attention to. Other things that we pay attention to for safety is Narcan, right? Arfair or naloxone is, I think, is the generic name, but Narcan is a drug that we give to reverse opiates. Now, understand that opiates last longer in the system, in our body system, than Narcan does. So if you get somebody who's been really, really sedated and had lots of opiates, you may have to put them on a Narcan drip. They're going to the ICU for that. They are an unstable patient. The other thing, when you give Narcan, they are going to wake up, and they are not happy about waking up most of the time because they're going to feel all the pain that the pain medications were covering. So we need to make sure that when we give them Narcan, be prepared that they're going to hurt. Now, Narcan lasts for a shorter amount of time, between 30 to 45 minutes, maybe up to an hour, again, depending on metabolism, but definitely shorter than our opiates. So be really, really careful when you're giving that Narcan that you're aware they're going to hurt. So we try to not give Narcan if we can wait it out a little bit, as long as it's safe and we're within our parameters. We're not going to give Narcan right away. All right. The other safety thing that we want to make sure is who can push the button. All right. Who can push the button? What's your guess? It is the patient, the client, whatever terminology your facility uses, but they are the one that can push the button. Family doesn't. I have actually had to respiratory code a 16-year-old because the family was they did not want her to be in pain while she slept, so they kept pushing the button for her. No, they can't do that. They also went to lunch, leaving her in a respiratory sedative state. She did fine. We just had to get her Narcan, but then that meant she also felt everything, and she was intubated for a short while we stabilized that airway. But she did okay in the long run. We just want to make sure that we're paying attention to things. So let's recap real quick. So we've got safety stuff that we're going to make sure we're paying attention to, that double check our vital signs and any assessment data, having Narcan on board, and then making sure we're doing the patient education with this. Also, we're looking at our settings, making sure they're accurate. Your doctor will give you an order with the settings in there. You can always advocate for more. And then understanding that we are giving narcotics, and so this can get kind of challenging. And then you already know all the side effects from narcotics. So we want to keep that pain under control so our patients can feel better. They can do their therapies. They can do all their things. They can get out of the facility sooner. They can go home, all that kind of stuff. But we've got to get their pain managed. Unmanaged pain leads to longer stays in the hospital and less quality of life. We want them to get up and out and get them moving on. Let me know if you have any questions, and we'll talk to you later.